could just give me a general background to what the healthcare industry is like in India.
Mm-hmm. Absolutely. Let me try that. I mean, it's a complex market, and I have been looking at this market for about 20 years now as an economist. And over time, I have been comparing what's happening in India vis-a-vis the UK and the United States, and also other peer southern economies like in the global south. I think some of the elements that stand out for me in terms of the healthcare environment in India is that it's a highly dual and deeply unequal system. So if you land in the Indian cities, you get a different type of healthcare than if you don't land in the Indian cities. And hence, you have to have conversations around health equity and justice in the way people are able to access healthcare in India. And this is not just an India problem. This is probably a problem of a large number of countries in the global south. If you go to South Africa, Indonesia, Philippines, Thailand, many places, you see this duality in the way health equity is distributed in the ecosystem. And that's something that, as an economist, you start thinking about normatively and from a perspective of distributive justice, who gets to access healthcare, affordability, and as well as quality. The second thing that I would say is, at least for my 20 odd years, but it started much earlier than that, from at least around 1980s. Indian healthcare system used to be a very public health system after the independence. But since around the 80s, there has been a lot of entrepreneurial entry in various subsegments of Indian healthcare system, whether it's in pharmaceuticals, whether it's in hospital systems, whether it's in med devices. So now we see a public system complemented with a rapidly growing private sector, and the government is trying to balance this duality that you see not just geographically but also in terms of how you distribute healthcare and what it means in terms of prices and outcomes. This also translates to this point that a lot of Indian healthcare system, in contrast to NHS in the UK here, is basically out of pocket payments. So if you have some issues with your, let's say, digestive system, and you have to run to a hospital, you don't really have an NHS number which will give you immediate access to a GP, and the GP could refer you to a upstream, more specialist physician depending on the conditions. It could end up being a direct run to a specialist where you are paying out of your pocket, and as a result, shocks to health in households are one of the biggest issues that drive families into poverty. So there is a beautiful paper by Manoj Mohanan in Duke University and his co-authors who show that suddenly if you have road accidents and you are getting these exogenous health shocks and you have to treat yourself because of these road accidents, it actually results in a lot of spending out of the households, making them more poor. Okay. Now I won't say the fun, but it's almost like the sad thing of all this is that at the other end you also see some very cool innovation and entrepreneurialism and amazing doctors who are struggling with this duality that I described and the inequality in healthcare. So you have these IU hospital system that we worked with for the data. There are some amazing business models, especially in southern part of India, in providing affordable quality cancer care. You have some of the amazing discovery research happening in med devices and in pharmaceuticals in clusters like Mumbai, not more Mumbai. I mean, it's more like Hyderabad, Pune, Bangalore, these three cities. So you have this duality. It's almost like how can both of these islands exist? At one end, you have these problems in the way you can access healthcare, and at the other end, you have some cool quality healthcare for which people are rushing to India or are recruiting Indian clinicians from the Indian context in overseas jurisdictions. So I think that's the challenge with the Indian healthcare system. And here, several solutions have been tried out over time, whether it's through health insurance or through entrepreneurial business models. My general observation, and we can chat more about this later on, is that such a mixed public-private system probably is improving over time, but there are boundary conditions to it. So you can only do so much if you have a not for profit eye hospital system that is providing quality of care, but you can't scale it and take it to outside of that location where they're located in, or even outside of India for that matter. So people have argued that this is something that one has to think through carefully so that this can be a model for equitable healthcare for around the world, because India is in some sense a lab for solving these dualities and these inequities that I described to you in just in the previous few minutes.
No, of course, and it's ultimately it's the most populous country on the earth now. So its healthcare system and its ability to manage people's healthcare is incredibly important for global healthcare outcomes. You talked about the dual system in India of its healthcare. Part of that is having an insurance-based system. A lot of people have insurance, and your research really looks into the financial vulnerabilities experienced, particularly by the elderly, in regards to some of these insurance. Could you just walk me through briefly the objectives and what you were trying to achieve with your research paper?
Absolutely. Look, the idea was there's a bigger debate broadly around the world whether insurance is good or bad for health. Okay, so you can see this debate in Obamacare versus now reversal of Obamacare in the US. There are experiments that have happened in Oregon where some households got health insurance and they were tracked in terms of how their health outcomes are. People have debated whether the NHS model is the right model to do, or do you need to become more pragmatic in terms of mixing up public healthcare with private healthcare? So in that context, as I said, from the 80s, as India started becoming more privatized in its healthcare options, these entrepreneurial hospital systems started coming in saying, we will try to solve the inequities in healthcare. And luckily, this particular hospital system maintain good data with electronic medical records. And I got involved with them with a Wellcome Trust India grant from 2020. And that's when I could realize that they're sitting on some amazing data to go back and examine this classical question in health economics, whether insurance is good or bad for health outcomes, right? So that's where the motivation started. And then we, with my co-author team, we dug into the data to explore in a particular context, which is pretty large, which is cataract surgery. And Indians suffered a lot from cataracts because it's also called the diabetes capital of the world. So much before the average household, you will see problems with all kinds of eye diseases that crop up in India because Indians consume a lot of carbohydrates also, and hence are diabetes prone. This definitely is more incident on the elderly population. So in the background, apart from that motivation that I described and the fact that there was data and the idea was to test whether health insurance is good or bad for outcomes, the other thing we are seeing in India is that there is a large population of elderly cohorts that are trying to access health, either from out-of-pocket payments or through private health insurance or by finding ways to get onto a public governmental health insurance system. Nobody really is talking about it in some sense in the policy space. More recently, there has been some buzz after our study that we should have more focused health insurance plans around the elderly. So the idea was to check in a specialized context like cataract surgery, what is happening to health insurance. So what we did was we measured health insurance uptake among elder people accessing cataract surgery in this particular sample, and that's a limitation of this study. We are working with a particular eye hospital system. It is a large eye hospital system, WHO approved and all that, but it may not be representative of all of India, and it may not be representative of all of healthcare. Nonetheless, it's a good, I think, robust sample, 38,000 patients aged over 70 who underwent cataract surgery between 2011 and 2022 in this eye institute across 4 Indian states. And we were trying to understand first who were the ones who were more or less likely to have insurance. So we looked at the heterogeneities there, like age, gender, rural, urban residents, socioeconomic status, occupation and comorbidities, etc., and whether they were having more private insurance or government insurance. And then we wanted to see, conditional on having health insurance, did it matter in terms of how long they waited for taking care and the health outcomes? Okay. And now, should I go ahead and tell you about the findings, or that's basically the broad picture of the study? So the broad picture was there's a debate on whether insurance is good or bad for health outcomes. In the context of India, there is a historical shift that's happening in this dual system, public and private. And the demographics show that increasingly the elderly population are falling out of the insurance bucket. So the question is, what does it do to health? With the case study of cataract is what we are trying to examine it. It's important that we had good data here. If we didn't have this data, maybe we would not have been able to examine it. And that's another important thing to notice for those who are listening to us, that having good quality, anonymized, but um, uh, analyzable electronic medical record data is so important, especially if you want to study such public policy questions. I mean, this comes back to what is happening in NHS also. A lot of hand waving going on without enough data being made accessible to researchers. But yeah, so that's the context for the study, Max.
Yes, Adi. And to sort of delve right into the results of your research, I think one of the things that the paper was highlighting is that as people got older, at least in those sort of analysed in the study, that insurance coverage seemed to drop off quite to at least a significant enough degree, which is interesting from my perspective, because you would think that particularly since healthcare costs are mostly borne at sort of the tail end of someone's life, at least in the larger costs. Obviously, there are certain costs associated with birth and stuff, but particularly they don't necessarily, the big costs don't come until later on in life. It surprises me to some degree that younger people would be more covered, and then older people would be there would be less coverage. Could you talk to me about some of the reasons why, or what the reasons you think why this is the case? Is it because premiums get so high when they get to the elder because of those associated costs that people just can't necessarily afford the coverage, or is there something else going on there?
This is indeed a result that caught our attention as well, and I think which resulted in us getting published in the Lancet outcome. So basically, the idea that you rightly caught on to was insurance take fell sharply with age, about 17.5% among the 70 to 74 aged, dropping below 10% for those above 85, and around 7% for those over the age of 90. Our explanation, and we need to do more on this, this is just our initial explanation, is that there may be that these folks who are not having enough insurance with age are the ones who are working with private insurance more than public insurance. And these private insurances may have entry age limits and rising premiums, and as a result, exclusionary barriers for those who are aging more. So I'll give you an personal example. My parents are in India, and every time I'm thinking of bringing them to the UK, I'm thinking of a travel health insurance for them. And the moment the insurance company learns that they are above 80, either the premium drops, and in some cases they're also not available. So it's very difficult to get elderly insurance for those who are coming for a couple of weeks to visit us from India. But that's for the travel health context. But in general, I think one can make a safe assertion that there are problems with accessing private health insurance for the aged in India, and that could be one explanation for this interesting finding that we have. The second thing is these elderly folks, 80, 90-year-olds, actually grew up in a very different policy environment. So this is like they probably retired around 60, and 20 years back, which is around 2005, they may have had lower lifetime incomes and more informal work histories, which means that they couldn't start off with an employer-linked insurance or make enough savings which can translate into better insurance coverage today. And that is something to ponder in terms of why this is happening. Of course, I mean, the other part of the story is sometimes elderly folks, unlike in the UK, for example, navigating paperwork and digital systems and hospital desks and staying on the calls and getting appointments, given all their cognitive issues, mobility, etc., becomes so difficult. I mean, here in the UK, you see much more comprehensive social support system in that context. But in India, the elderly are left to themselves, and sometimes they just feel like, who the heck cares about this stuff, right? So this is too complicated for me. I might as well not take it and go to my logical conclusion in life. There's a culture element here as well, which I think is a little bit of fatalism, which is after a certain age, folks in India may be thinking that why spend on my health? Might as well transfer the money that is left perhaps for the grandkids' education and things like that. These are all hypotheses, by the way, Max. We don't have a proper answer here in the data to know what exactly happened.
Sure.
But I think those are the four things: age unfriendly insurance design. There are some cohort effects and informal work histories that did not translate into more financial endowments today for accessing insurance, administrative barriers, and lack of social support system for the elderly in India, both in urban as well as in rural India, worse in rural India, and then some cultural aspects in the way people think in planning their lives towards the end. So I think those are the things that are driving that particular result.
Yeah, that's actually one of those points there is actually something I hadn't necessarily thought of, because as you point out, the elderly in India are coming almost from like a different age, obviously, in India, and India's experienced a lot of rapid growth in that time. And even healthcare outcomes over the last 2-3 decades has actually been quite significant. I mean, if you look at things like infant mortality rates, dropped from about 39 deaths per 1,000 live births in 2014 to about 27 in 2021. Life expectancy, to your point, has gone from about 63 years in 2000 to 70 years in 2023. And the presumption would be that in 2024 and 2025, this is only going to get better and better and better. With that context, to your point, it sounds as though it's actually not that much of a jump to make that if individuals were making decisions about their lives, their healthcare, and their general planning, with the expecting they were going to die at 60, they might have actually not necessarily been planning for to live to 70, 80 potentially. And so they might just not necessarily have the savings to maybe cover some of those insurance premiums potentially. And so it might be this case of you're not necessarily having to forecast out these kind of things. And it wasn't necessarily bad planning. It was just you were going off the information you had at the time. But given the healthcare has actually improved to a degree, it's actually led to these kind of almost like negative externality outcomes in maybe some of the planning, which is interesting. It's not something I'd necessarily thought of. With cataract surgery specifically and some of these healthcare stuff, it's pretty well documented that better healthcare outcomes generally leads to a healthier, more productive society, at least to some degree. The anecdote, I'm from the UK, obviously, and so a big push for the public healthcare sector, the NHS, came after World War II when they realised, after both World Wars, that actually the population wasn't necessarily in a very fit and fighting state.
Yeah.
And so that's what sort of drove the incorporation of the National Health Service. Can you talk to me in regards to how you anticipate things like not getting the ability to access things like cataract surgery could actually impact on economic productivity of India more broadly?
I personally think that a lot of folks are actually okay. Let me take a step back and say a few things on that question. It's a very, very important question. So,
Sure.
I think that given the economic conditions pre and post COVID, and we don't have that in our data, but we were certainly in our data leading up to COVID and things like that. In general, people were working longer in India just to maintain their income viability and contribute to the household incomes, etc. So in that world, if you are going to have cataract, that will translate into productivity shocks. And while there are no estimates out there, in fact, that's a logical extension of what we should be studying, which is because they are not having better health insurance to solve cataract, what is the role of that in how many times they are able to show up for work, or what is happening to their absenteeism in the workplace environment? There are results in our study around this being more for women than men. So if this has more deeper negative productivity effects on how women get affected more in this conversation than men, then we have to redesign our both public as well as private health insurance system such that it takes into account these potential costs from having a bad bad eye situation because of avoidable blindness and cataract. The other thing to note here is that a lot of elderly people in India, because of the way family structures are doing a lot of unpaid care and household work. So they may not be actually working, but they are helping in babysitting the grandkids and the soft stuff at home, right? Managing.
Yeah, other unpaid labor stuff.
Yeah, unpaid labor. So how do we estimate whether poor vision is affecting this unpaid labor? We don't know, but we need to do. No, I mean, this is one of the limitation of the study, which is we didn't have much qualitative surveys to complement our data analysis. That would, I think, bring out how the productivity effects are affecting folks as they age. And it's also a safety and dignity story. So when you start seeing, you may have noticed this. I have parents, my wife has parents who are having issues with age around eye care and hearing. And as they have those issues, they are potentially like facing a stigma. They don't want to talk about it because they will be like labeled as getting old, not able to see much, not able to hear much, da da da. It's a personal hit, right? When we get old and we start having issues with eye care or hearing problems, we don't want to reveal that to society because in a context like India, this is not potentially going to be taken in the right way. You might be fringed out within the household if you were helping with the grandchildren. You might be terminated in your jobs if you start talking about it and you are nearing retirement ages. So these are things that we have to think through in terms of what the productivity effects are. Productivity can translate from some sort of a path dependent story where people are able to work perhaps less productively because of declining eye care, vision. But it could also come from the way society is structured and the safety and dignity aspect of individuals. And it is sad to see in our results in some sense that the more you age, the less you have health insurance, whereas you also see at the same time having health insurance is actually giving you better outcomes, which means that if there is a positive intervention either through like an elderly targeted public health insurance system or through a private health insurance model that looks at the elderly, that could translate into proper national productivity positive outcomes. I don't know of that conversation happening in the Indian public health debate. I have seen some recent newspaper items talking about redesigning the public health insurance system because it has broader spillovers on productivity in the way we just discussed. But I haven't seen like any robust move yet. So I'm hoping that the results actually translate into some policy conversation and changes because there is a role that the elderly play in our world, not just from a productivity perspective, but from wisdom, from experience, from giving you a sense of how history is moving around the world. We live in a very volatile, uncertain world. Just I get this perspective every time I talk with my dad, to be honest. And I don't want him to be not around me because every time I have to like brainstorm about something happened somewhere. And he's like, I've seen that 30 years back in that context. He always has something like that, right? So that's also productive for me to get perspective. But who is going to measure that? And if there's a value of that in society, then are we doing enough, whether it's India or anywhere else, in taking care of that value? That's the policy point I want to raise to those who are listening to our conversation, if that makes sense. Big picture, India is aging, unlike the common narrative that India is a young country. Um, in that world where India is aging, our study shows that a lot of them do go through vision issues and they are not being properly safeguarded from a health insurance perspective, especially as they age further. The data oriented positive economist will look at this and say, well, maybe that's rational because they're not productive enough, they're not valuable to the economy. But are we measuring productivity in a proper way is a conversation I want to raise from our findings because the elderly contribute in many ways, not just from a measured way, from a productivity perspective. And lastly, there is a little bit of movement on how elderly health insurance should be structured in a public and private sense, but not too much nationally in India. And that's something to ponder, not just from a public productivity perspective, but from a safety and dignity perspective.
Sure. And obviously, your research here specifically focuses on patients with cataract surgery or looking to get cataract surgery. Can the findings here, at least in your view, can they be extrapolated out into other areas of the healthcare industry more broadly across India? So maybe diabetes or like other things where insurance would need to provide coverage.
I think yes, with some caveats, of course. So, for example, as the elderly age, they also go through knee problems, and they want to do like knee replacement surgeries, total knee replacement surgeries. This is a big issue in India, and osteoarthritis is on the rise. So, unfortunately, we don't have data around it. We got data around cataract and eye surgeries, which goes back to my earlier point about the importance of electronic medical records. But I think that if you take this data to that kind of context, like total knee replacement surgery, which affects the elderly, you will potentially see similar effects. The core pattern, which is low insurance coverage among the elderly and sharp drop off with age, gender, and rural locations, and if they are insured, better outcomes. I don't think that is unique to cataracts. You take it to other health conditions, you should be probably seeing this. It is a limitation of our study, but it should start a conversation of taking our study's findings in other settings in the health context. The other thing to note here is that cataract is mostly surgical and inpatient, and relatively inexpensive per case. If you go to TKR, total knee replacement, for example, it is also surgical and inpatient, but it's not inexpensive as cataract. So you have to stay in the hospital for a couple of weeks, and then they will release you, and there will be like 15 additional days of physiotherapy and stuff like that. So depending on the financial intensiveness of the geriatric condition, I think we will see some variation in our findings. But I would definitely argue that a broader problem of financial vulnerability among the elderly in a context like India is definitely brought out through this cataract story. It does have an internal validity issue and may not be completely externally valid and generalizable, but just from the two examples I gave you, I think if people can dig out the data and get into them, we will see more of similar patterns. And I say this from my own past studies in other contexts in Indian healthcare. So, for example, there's a big conversation in Indian healthcare around quality of drugs and medicines. And the question is, how do we have substandard generic pharmaceuticals so prevalent and prescribed in India? And I found in an earlier study that surprisingly, even specialist physicians and in big locations like Mumbai are stuck with prescribing less quality drugs. And the question is why, right? And the question is also whether this is generalizable to all types of drugs. I was working with, I think, some cardiac drugs. This is a broader conversation. People know this anecdotally, but that particular paper raised that conversation in a more structured, empirical fashion. Here, we are doing the same thing. We are showing this in cataract, but I am hoping that future generation of researchers will pick up this study and try to see this in other geriatric health conditions and see perhaps similar elasticities or lack thereof in terms of how the elderly access health insurance in a context like India. And from there, more normatively design healthcare for the elderly in an aging world.
Yes. And obviously, despite the things that we've spoken about there in terms of some of the deficiencies within the Indian healthcare system and how it operates, it's undeniable that, as we've also previously mentioned, that healthcare outcomes have certainly improved over the last several decades in India quite significantly. Are there any particular programs or changes to the healthcare system that you think has allowed for those health outcomes to manifest? I know we've previously spoken about how in the 80s the sector was more public, and in more recent times that there's been a more incorporation of the private sector. Do you put these healthcare outcomes coming down to more on entrepreneurship, or are there specific government programs, or quite frankly, is it just a case of the country getting wealthier and being able to spend more money on healthcare?
Amazing question. I don't know the answer to it properly, and I would love a PhD student to do this dissertation research with me, maybe you, Max. But I think, yeah, this is seriously a beautiful question because I often wonder whether it is entrepreneurship or whether it is wealthy is healthy or whether it is some interventions to solve the market failures here, like public health insurance system. Now, you have different apologists for each of these arguments. So, the health entrepreneurship ecosystem is going to argue it is us who is changing the way health is accessed and outcomes are bettered over time in India. And I know a bunch of health entrepreneurs, whether it's in Bangalore and Hyderabad or Pune or Mumbai, talking exactly that talk. And I see them with some skepticism because I wonder whether you have control for other things going on in the environment. The governments, national and provincial, state level, are going to argue, well, health is a matter of votes, and whatever denominations we might be coming from, left, center, or right, we have to take care of people's votes. So over time, we have seen more and more state and now central health insurance system, universal health care, taking care of the health of the poor. They know it's an easy way to get votes. Whether it's resulting in actual efficient deployment, steering clear of the frictions that exist in the system, not so important. What is important is you should be seen as a government who is taking care of healthcare for those who are not able to access health. So it could be the health insurance system that is changing the complexion of health outcomes in India over time. And at the same time, it could also be the standard Angus Deaton style wealthy is healthy, but up to a certain point kind of a debate, right? We have the Preston's curve in that conversation that as you get wealthy, you become you have extended mortality. I mean, you have extended livability, and after that, there are diminishing returns to this. So I don't know how to test for this and which is the causal explanation here, but my sense is it's a mix. It's a mix of all the three things. And if you run a horse race model at the household level, where you are trying to test for whether it's entrepreneurship or health insurance or the country becoming healthy, maybe we'll be able to tease out what actually won in that horse race. Is it public policy? Is it the entrepreneur who is designing cool business models, like let's say LV Prasad is doing with eye care, or is it a general secular thing macroeconomically that India is spending much more on healthcare? Not enough, but much more on healthcare as a share of GDP, let's say from 15 years back. This is seriously an amazing question, and I'm glad you asked it, but I don't have an answer, unfortunately, to it.
Well, clearly, I think some future research and stuff can be sort of maybe outlined to look at this stuff, because obviously, India is obviously a developing country, but it's certainly getting towards sort of middle income status and stuff. And so, considering you have other countries in the region that are still developing and have sort of worse health care outcomes, something like that might actually be able to that kind of research could maybe be really beneficial to a Bangladesh, Pakistan potentially,
Yeah.
To enable to sort of increase these health outcomes. You briefly mentioned this at the start when we were talking about the general healthcare environment. But given that India is such a big country, not only in terms of population, obviously, but also in just terms of size, geography as well across the country, it sounds as though and this is kind of what I expected from doing some preliminary research, but it seems to be a lot of inequality when it comes to healthcare between regions and being able to administer consistency in healthcare across the vast swathes of the population, whether it be geography or age demographics or whatever. Could you speak a little bit about what is driving some of this inequality regionally in some of the healthcare outcomes, and how certain things could potentially be mitigated potentially in the future?
Absolutely. And again, this is another dissertation topic. I'll make some speculations and I hope people pick up on that and test it in data. So, what happened in India is the southern part of India, especially Bangalore and Hyderabad, they benefited from a subsidy system that resulted in the formation of these big software companies that we know of today and that supplies cheap labor to around the world, right? The Tata Consultancy Services and the Infosys of the world. Now, there were positive spillovers of that into the general economy in those contexts, Hyderabad, Bangalore, and the southern states. the life standards improved in those regions, and folks who moved out from India, let's say in Silicon Valley, started thinking about what to do to improve healthcare in those regions. And they brought in a lot of insight, expertise, technology from their general wealth that they accumulated and changed the flavor of how healthcare is distributed just in the southern states. Now, as that was happening, the northern states and the eastern states and the western states, western is also very wealthy, Mumbai and others, were looking at southern India and its broader macroeconomic positive welfare implications. So they tried to catch up, but they didn't have the wealth to catch up. Neither did they have the individuals to do the business model interventions that were required. So all these interesting Harvard case study type of eye health system or heart health systems, they're all coming out of southern India. Some new interventions are coming up from Western India, but the North and the East still fail to catch up with the description I made of how things changed in Southern India. So there's a lot of internal migration in health. People access health within India. If there's something complicated in the eye or the heart or cancer, they basically catch a flight from Delhi to Bangalore to get themselves treated. They don't treat themselves that much in a northern context or in eastern context. Now, what is the lesson from this? I think the lesson here is that there are some agglomeration economies happening, which could be used by the policymaker nationally, saying that, fine, maybe the southern part has some comparative advantage because of other things happening in the broader economy, software, and the change of India, da da da. Let them have that comparative advantage. We will do other things where we have comparative advantage in. And let me facilitate the trade in accessing health from the south. Some of it has happened, some of it has not happened. And the bigger political economy debate here is that there's a constitutional provision in India, and successive governments have tried to change this. So right to health is basically a state subject in India, which means that if a state feels like it wants to get or create an ecosystem for amazing healthcare, it can go in a direction that is orthogonal to, let's say, the national direction. And because there is this constitutional provision that right to health is a state subject, every time a government has tried to implement a public health insurance system that is national, there are always certain states and provinces that are saying, oh, we won't align with that government's ideas because we are not politically aligned, da, da, da. So, I mean, the frictions that has existed never get ameliorated because of this political economy issue. Although South has risen as a hub for health access and health innovation and quality of healthcare in general. I think there's also a role here of education. Southern states are more educated. So health seeking behaviors are therefore very different and better in the southern states, if I can call that, than, let's say, health seeking behavior in the north and in the east. There's a ton of literature in health economics that shows that better health seeking behaviors translate to lower burden in terms of health and access to health issues. So I think these two, this other thing that was happening in India macroeconomically, the rise of the software sector, southern India becoming more prosperous, and then the entrepreneurs came in and brought in their business model ideas. The second thing is that there is this right to health distortion that is there that is preventing homogenization of health access. And the last thing is that education may have played a role in the subnational heterogeneity that exists in India today in the way health is accessed and treated. If that makes sense, Max.
No, I think a lot of that makes sense, to be honest.